Hey everyone, how's it going? Oh, hello, Selena. I just couldn't get enough Epi bios, so I came back 2 days and I cannot blame you. Hey, Allison. And as always, we'll get started here in just a few minutes. Yeah, I was wearing a tie for interview, so I said, you know what, might as well class it up a little bit for the people who already made it into the club. So. Okay. Shelby and Rachel, good to see you all here. I forgot to click the publish button again on the epidemiology section on the class, but I did that probably like an hour and a half ago, maybe. So you can go and get the slides there. I put up the first two PowerPoints. I'm still working on some of the rest of them. Casey, can't relate. As soon as we were done with the interview thing, I immediately went back into PJs. Yeah, I don't blame you. Nice thing about working from home, one of the few things is, really only the top half has to be professional. Bottom half can be anything at all, sweatpants, whatever. Haley? How were the interviewees? Were they up to your exacting specifications? Cool. Good and so nice. That's fantastic. Yeah, we had a pretty good group. It was me, Dr. Butler, and Professor Kaplan interviewing together. So pretty tough crew there, but they seem to do okay. Pandemic has taught me there are two types of PJs. There are the daytime PJs and sleep PJs. I'll do you one better, Isabel. You just have them all be the same PJs. That's all. Oh yeah? Well, hopefully they had good things to say about my interview with them. Hopefully I didn't scare them too bad. I'm trying to remember if I remember your interview, Molly. That's the problem is like you interview so many people that you forget like who you actually had interviews with or not. And so students will sometimes have PTSD and be like, "You were so mean during your interview." And I was like, "I have no recollection of that." Well, hopefully I was nice during all of it. That's a good thing. Hopefully I don't scare them too bad. That's a fair point, Matt, for sure. Oh, I probably did say that. Well, hopefully it did not come to be true. I just said on average, people tend to fail my test if they're going to fail any test. So it's not saying you in particular. That is a key distinction there. I was trying to use my stats lingo to keep myself out of trouble from saying you're going to fail in PA school. It's like, no, my tests are tough. No sweatpants for you. Yeah, I'm all gym shorts, basketball shorts. Paige, we do that for every we do that for every single person. They're like, what's the toughest class you ever had? And they're like, organic chemistry. I barely passed it. I almost had a nervous breakdown. And we're like, okay, so there's gonna be 5 of those. How are you gonna handle that? Yeah, so everyone gets that one. It's kind of true, right? Like, hopefully, you kind of feel like the volume of stuff you're learning is about like that. So, nope, you're here, Paige. You're stuck with us one way or the other. Was my favorite interview question. Let's see, it's time to start, but I'll say my favorite one. I had one person who, in their personal statement, they're talking about Harry Potter. They're talking about how going to Harry Potter, or how PA school is like going to Harry Potter. And so then I went ahead and said, okay, well, what house would you be? And their eyes lit up. I've never seen someone so excited to answer an interview question. And they said, well, I think everyone wants to be Gryffindor, but I really think deep down I'd actually be a Ravenclaw because they're really smart. Blah, blah, blah. It was just Very funny to see her get all excited. Anywho, let us begin. I've started recording. I realized last time we had farm that I accidentally opened up the wrong sticky board, so I'll answer those questions that are on there next time, but I have the correct one open now. I did want to show you a picture that I forgot to bring up that someone reminded me of. A student had sent me this a year or two ago, trying to give us further clarification on type 1 versus type 2 errors. So, you know, that you can always use that as your go-to example for you're pregnant or you're not pregnant and which type of error you might be making there. Anywho, let's get back into talking about epidemiology, right? So we're kind of switching gears a little bit here and discussing, well, I don't know if it would help just too much before the test, Nicole, but it'll certainly help you for this upcoming section. We talk about positive predictive values and things like that. But anyway, we're switching gears and we're talking about epidemiology. And so we're kind of going through the principles and beginning intro portion here. And we'll see if I can get to the next PowerPoint or not. So here are the objectives we're going to be talking about. Basically, what is epidemiology? Well, it's kind of like the study of distribution in terms of disease in a human population. So instead of looking at very small numbers, we may be looking at more large scale things in terms of populations. It could be people in an entire country, could be people in a very certain area, just kind of depends. And so it kind of comes from the term epidemic, which some of you may be familiar with that term recently, is Greek for upon the people. And so again, we're trying to see like, what's this kind of burden of disease upon the people? What sort of interventions can we have on that? And so really any epidemiologist is someone who kind of studies disease frequencies and populations. They try to look for like risk factors and they look for connections between people's beliefs, people's habits, all these kinds of things, and then look to those connections to disease to see how can we ultimately improve health for the population, right? And health being basically, as defined by the World Health Organization, is this sort of state of physical, mental, social well-being, and all of that, right? So this is kind of what we're trying to focus on. How can you overall increase health for the population? So, and then we're going to see that a lot of what epidemiology focuses on is frequently preventative medicine. Again, we're trying to, or at least the old adage is always, you know, an ounce of prevention is worth a pound of cure. So if you can prevent disease, that's always going to be much more cost efficient and effective in terms of like quality of life and things like that for patients, rather than treating a disease that's already occurred. And so that's where a lot of things like public health initiatives come into place here to try to apply some of these preventative principles to the population. So for instance, if you ever see like the Florida Stop Smoking line, I can't remember what the specific name of it is, but there are funds that are set aside by the Florida Health Department to an organization that funds all these things to where they help people stop smoking, because they know that they help people stop smoking now, they can prevent a whole lot of diseases down the line. And that's what their whole business is basically. And so we're looking at epidemics. You know, we may be thinking about it being restricted to one sort of location. So for instance, when we had, I think we had like a rash of, not an actual rash, but we had an outbreak of cases of hepatitis A, I think within the past 2 years or so here in Florida. That is where you kind of think about an epidemic as being sort of in a one sort of area. Yeah, that's exactly right, Isabel. Tobacco-free Florida, that's what I was thinking of. Thank you. And so then we think about pandemic as being more substantial to a large number of people, right? Kind of attacking multiple countries, multiple continents, things like that. Obviously, we're in the middle of a pandemic currently as it is. And so when we're looking at that, we want to look to be like, why is all of a sudden a pandemic or an epidemic sort of occurring now? And a lot of times it can be related to a number of different things. So for instance, here, if you were looking at like a specific infectious disease, you may be looking at things like increased virulence of the organism. Maybe you've introduced it into a novel setting. So for instance, taking a disease that is endemic to places in one area and then introducing it into a new area. Could be you now have a new susceptibility in the host to the infectious agent, right? Maybe people have a new susceptibility either due to genetics or some other factor there. I'll get to that in just 1 second, Matt. Or it could be a change in the host exposure to the infectious agent. So perhaps if someone is a non-IV drug abuser and then they go and start to use IV drugs, they now have new exposures to different infectious agents there. And so again, epidemics don't have to be contagious necessarily. You know, you can have things like obesity, for instance, or opioid use disorders, are considered to be an epidemic, right? And so Matt's asking, like, well, how big does it have to be an epidemic, right? Basically, what you're looking at, and we'll talk about this in more detail later, is you have to look at what the baseline levels are and then see what the new current levels are. And if you're getting a spike that is very much out of the normal for what would be expected, you can consider that an epidemic, right? So you can even look at, for instance, like the flu. We know we're going to hit flu season every single year. It just always happens around the winter time. We can look at what the average levels are and then look at what the current levels are to see, well, is this really out of whack compared to what we're used to seeing, right? So you wouldn't compare January to July because there's almost no cases of flu in July. Probably shouldn't be any. But if you were to compare January of 2020 versus January 2019, you can compare those two to see, okay, what's the average and what are we at now? And if it's just, significantly higher, according to whatever organization, whether it's a health department or the CDC or whoever, they can then classify that as an epidemic. But basically, it's out of proportion to what is considered normal. Just to give you an example of how epidemiology has been used sort of clinically to help improve health of patients, here's an example of something called childbed fever, or basically this puerperal fever. It was a bacterial infection that was basically women who had recently given birth or had a miscarriage. They were developing these bacterial infections. And so this was something from, the 1600s up to the 1800s. We really didn't know why it was occurring there. And what we actually ended up finding, it was actually caused by the physicians themselves causing it. And so it's kind of interesting how they figured this out. And so basically, this is a long time beforehand, but even before they knew what germs were, they didn't really think that hand washing was super important, like we realize that it is nowadays. So you had all these doctors practicing in the olden times, no idea the hand washing was important. So obviously, you can already probably see where this is going to go. But actually, it's even more interesting than that. So in 1844, there was this guy, Ignaz Semmelweis, I'm assuming from Germany. Actually, it was in Vienna, so I guess Austria. He was basically a physician who was working in this obstetric division of this hospital here, right? And it was where medical schools were basically receiving their training here. And what he noticed was that in his wards, they had a 16% mortality rate from their patients who were in their wards giving birth. And then there's only 2% mortality in this other division where they had the midwifery or the midwife students who were training. Now that really seems like out of proportion. Like, what is it? There's a difference between medical students and doctors than it would be with midwives, right? Is there something different in their technique, or what in the heck is going on here? And so what he noticed was that the fever was rare in women who gave birth before arriving to the hospital as well, right? And so part of what being an epidemiologist entails is being a detective, right? Being able to look at sort of what the trends are, look to see what the circumstances of a thing were, in order to see kind of what's really going on underneath the surface. And so he also noted that physicians in the first division, where all that extra mortality was occurring here, they were performing autopsies each morning on women who had died from the previous day, but the midwives were not required to do that. Keep in mind, they're also not washing their hands. So he was able to make this connection between people doing autopsies and then going and delivering babies. When his one patient actually died of septicemia when he cut his hand after performing an autopsy. So even before they knew what germs really were, they were able to kind of connect these two disparate things of performing autopsies to these women who were dying after giving birth, right? And so they looked at various cleaning agents, and he basically was then ordering all doctors and students who were going to be working in this ward to basically use this chlorinated lime solution, right? And so they said before working each day and then before each vaginal examination, they had to make sure they cleansed their hands there. And what do you know? The rate of death here, the mortality rate, went from 18% to 3%. Pretty incredible, right? And again, that's one of those things you can see kind of post and pre and post. Oh, wow, that seems pretty extraordinary there. But even then, because we didn't really have germ theory by that time, it was still met with a lot of skepticism and ridicule, right? So just one example. There are many more that we'll talk about throughout this class here. But essentially, we're looking at epidemiology. We're studying something that afflicts or affects a population to see what happens in terms of their health here. And so we can look at the different factors of a population and of different host factors and different pathologic organisms and things like that to try to determine what the normal occurrence and distribution of a disease in a population is. So for instance, like you'll find certain things that are linked to genetic predispositions, right? Like you typically see patients with sickle cell disease typically come from a certain ethnicity versus patients who, for instance, trying to think of another case, or like, for instance, cervical cancer is probably not going to happen very often in male patients, right? So a lot of these things you're looking at to see what are the normal occurrence, what's the distribution of disease in a population. You can kind of look at it at several different levels here. You can go all the way from, say, the actual genetics of the patient, the immunology, the biochemistry, all the way up to the actual populations themselves, right? And so based on these studies and based on what we find, we can actually then take this information from the population and then bring it back to our individual patients. Because that's ultimately what I wanted to teach you. It's how to take information that may apply to a lot of people and then apply it to your individual patient, because at the end of the day, that's all they care about is themselves, right? Because they want to get better. They want to make sure that they're being taken care of. And that's what your job is, to take the best care of them as possible. So there's kind of two forms of epidemiology. There's sort of like the classic one that's more sort of population oriented, where we can do studies looking at communities and seeing kind of what's the origin of health problems. We can look in particular, infectious diseases were sort of the more common ones you see there. You could look at other things too, like their human behaviors. You could look at nutrition, social and spiritual state of the population. All these things can have big influences. And I'll show you some of these examples here in just a little bit. With more clinical epidemiology, this is where we're going to be, again, taking it more back to kind of what we talked about with biostatistics and being able to use research designs and statistical tools that are able to help us evaluate smaller groups of patients and then be able to do things like try to improve prevention of disease or try to detect disease earlier. This is where we can do studies, for instance, to come up with new, say, for instance, like a risk stratification scale to see whether a patient needs a CT scan after coming in with chest pain, for instance, right? It's a big clinical dilemma for a lot of people there. And so that can help us to adjust for things like comorbidities and different clinical treatments and whatnot. So when we're looking at the stages of disease, we can see there's several periods here. There's the pre-disease stage before any sort of pathologic process is actually already started here. And this is, again, where you're going to be able to get sort of the best bang for your buck in terms of prevention, because they don't have the disease yet. And so you can introduce early things like, for instance, washing your hands can help to reduce infection, right? This is called primary prevention, where you actually prevent the disease from occurring in the first place, right? Next, you have things like latent stages, right? Where the disease has already started, but maybe the patient's asymptomatic. And this is called secondary prevention, where we can do things like screenings and initiating appropriate treatment before patients become symptomatic, or if we're trying to prevent them from becoming symptomatic. So for instance, doing things like self-quarantining if a patient is feeling bad nowadays, they have fever and things like that, or by doing, for instance, things like COVID screenings and things like that can be useful to try to prevent other people from becoming infected, for instance. And then we have the symptomatic stage, right, where the actual manifestations are already pretty evident here. And this is where we're more focusing on tertiary prevention, where we may be trying to slow down, stop, or if we can, reverse progression of disease, right? So if you have a patient who, for instance, has rheumatoid arthritis and they've already had pretty significant joint deformation, how do we slow that down? We may not be able to reverse everything, but we can try to at least slow our rest. And that's more of a tertiary prevention sort of strategy. So we want to also focus on the mechanism and the causes of disease, because if we can understand that, then it kind of makes more sense when we're trying to be able to piece together cause and effect here. And so if you can try to link it back to certain biological mechanisms and or things like social environment, the environmental factors, all of these are going to play a role here. So for instance, here's an example of osteomalacia. So in terms of different causes for this, here's one example where social and biological causes could be due to purdah, which is something practiced in the Muslim faith where much of the skin is covered. And so obviously you would see less vitamin D production being produced as a result of sun exposure to the skin, right? Or they may have deficient dietary intake from, certain reasons, dietary intolerances or other things. You can have, as a result of that, then you can have things like maternal and fetal mortality due to distortions of the pelvis because the bone is not as strong and it has deformations there. And so looking at that, you can see that a social or in this case, a religious sort of practice, has led down to things like fetal maternal mortality, right? And again, these are kind of knock-on effects of the practice. And so if you can identify those patients and say, okay, well, these are things we should do to try to prevent this from happening, you're going to get much more benefit than if you try to fix, a patient who's already become ill because they're pregnant and having increased risk for fetal mortality, for instance. But this is what we're looking at. This is what we're trying to link together either biological, social, environmental factors into preventing disease. Okay. So anyway, so we can see that there's sort of a triad of factors that cause disease. You probably cover this in your microbiome class already. We're going to look at also basically the host, the agent, and the environment. And we can also focus on the vector as well. So I think malaria is a pretty common example here where we are the host, being humans. At least most of us are, I believe. And then you have the agent, which itself is this plasmodium. There's a few different species there. That's what's actually causing the disease itself, although it doesn't have a really easy way to get into us unless it is going to be traveled or being transported through the vector, which we know to be the Anopheles mosquito. And then certainly we know that environment is important because Anopheles mosquitoes are going to be more present in certain climates than in others. So for instance, like in tropical climates, you're more likely to see malaria than in places that are, say, very dry and arid, for instance. And you can see there's always a relationship between all of these things. So for instance, how could I change the host factor to prevent malaria from occurring? Well, I could remove the host from the environment, or I could do things to reduce the vector from potentially interacting with the host, right? Things like, mosquito nets. I could prevent the agent. I could give things like anti-malarial drugs as a prophylactic potentially. There's things you can do with all of these in order to try to prevent ultimately the disease in question. And so we'll see here that things like host factors are going to be responsible for the degree to which a disease individual is either susceptible or perhaps resistant to the agent itself here, right? And you can see here that even host influence or host resistance can be influenced by things like genotype, right? So for instance, patients with darker skin color tend to have less sunburn, also probably lower skin cancer rates, for instance. Or if you have a high BMI, that's a host factor that makes you susceptible to all sort of metabolic conditions like diabetes and hypertension and whatnot. What if you have an immune system that is not functioning properly? You are certainly at risk for more infectious diseases. And then looking at social behaviors, for instance, if you exercise more, you're probably more resistant to certain diseases than if you were to not exercise. Although maybe you find more sprains and fractures and things in people that do exercise than those that don't to some extent, right? So it can kind of cut both ways there. Not that I'm advocating against exercise, everyone should do that. But also looking at the agents of disease, you can see that there's a lot of different things that fall into this, like biological agents, like infectious organisms, chemical agents. This is one I care a lot about because of my background in toxicology. We always practice for things like mass casualty events. So in case, a tanker full of chlorine spills over on the 417 and a ton of people are affected, or in case there's a carbon monoxide leak in a building or something, or due to a fire. All these things can be chemical agents, and certainly physical agents like heat, cold, noise, and then a lot of social and psychological stressors. Like my class is probably a psychological stressor, which may be an agent of disease, right? Could be intense anxiety or PTSD perhaps. And then looking at the environment, this can certainly influence the likelihood for contact between the host and the agent. So if you have, for instance, poor restaurant sanitation, you are more likely to have exposure to things like salmonella, for instance. One of my favorite restaurants ever was a Chinese buffet up in Jacksonville called Wasabi's, and it was an all-you-can-eat buffet, and they had all this wonderful sushi that was out, but of course, what did they get closed down for? Huge sanitation violations. I was at major risk for having some severe food poisoning from that place, but I got lucky, and then I think they burned it down for the insurance money, and ironically, it was right next door to a Firehouse Subs, and that burned down as well, so it was a doubly sad day. Anyway, but other things can also fit into that. Things like crowded living arrangements, right? People going out to public events nowadays may predispose them to COVID, for instance, right? Try to keep this somewhat topical. And then looking at the vectors of disease, of course, we always think about things like insects and arthropods, maybe rabies and, animals that carry rabies, for instance. Yeah, your favorite restaurant closing is the worst form of heartbreak. I certainly I can agree to that for sure. But You could even think about human beings could be potentially a vector too, right? So if you imagine someone like who is a dealer of illicit substances, say an unlicensed pharmacist, if you will, they may be passing along drugs where patients are more likely to use contaminated needles and things like that, and that could be potentially a vector. Some of this you may have to stretch your imagination a bit there. But overall, the vector has to have a specific relationship between the agent, the environment, and the host. It's a very interconnected web there that we try to establish when we're trying to look at new incidents of disease and things like that. So to go into that, there are risk factors that can be associated with disease I kind of want to talk about, and this is called the Beings model. And it covers several different things here. I want to give you some examples because I want to start to sort of get your mind thinking about these things, to think more like an epidemiologist might, which is not difficult when we live in the middle of a pandemic currently. You might be thinking about these things already. And so beings can be broken down into biological or behavioral factors. You can find environmental factors, immunologic factors, nutritional factors, genetic, and then services, social factors, and spiritual factors. A lot of these things are pretty intuitive once you kind of read through them, and I'll show you some examples. But this is just a nice mnemonic to sort of bring them all together. So that way, when you're thinking about it, you can kind of look at each one of these things to see where they may be having an influence on kind of what's going on currently. Let's look at biological and behavioral factors. Certainly from a behavioral standpoint, this is a huge one, right? And you can see that certainly from a biological standpoint, lots of things about a person's biology can affect their susceptibility to disease. Their weight, their gender, age, bone density, their type of lifestyle, all of these things may have a role to play depending on the disease state we're talking about, right? Smoking is a huge one that we think about for things like MI, COPD, lung cancer, all of that. And you can see that, cigarettes are responsible for many cases of MI and lung cancer, at least they're closely associated with those things there, right? This is a behavioral factor. So if you can introduce something like tobacco-free Florida to get people to quit, then maybe you could help have a significant reduction in some of these outcomes, right? Not complete reduction because there's other causes, but maybe a significant one. We're looking at like obesity, how we know there's so many disease states that are associated with obesity, high BMI, just things from lung disease and hypertension and diabetes and kidney disease and all these other things there that it's leading it to be more and more of a cause for premature death in the US. And again, that's more of a behavioral factor and a biological factor. It's kind of a combination of the two depending on the patient, sort of what their kind of background is. And so looking at this, you can find that multiple behavioral factors can lead to spread of disease or injury, right? So for instance, you can have things like HIV and AIDS. It can be related not only to things like IV drug abuse, where people are sharing needles potentially, but also things like unprotected sex, right? So you can have multiple behaviors that can ultimately kind of lead to the disease state in question. Or if you have excessive alcohol intake, we know that causes a ton of things like cirrhosis and pancreatitis. And then certainly we're still in the middle of a opioid use disorder epidemic. And so we have a huge number of overdoses, right? And you can see these shifts and things occur over time as the environment changes. So for instance, within Florida, we had a ton of pill mills that were sending out huge amounts of oxycodone and hydrocodone to patients with illegitimate scripts. And all of a sudden we shut that down. We cut down a lot of those pill mills, arrested a lot of doctors and pharmacists. And then what happens? You think all the opioid abuse goes away? Well, no, it just switches over to whatever's most available. Now we see a lot more heroin deaths. We see a lot more fentanyl deaths. It's mixed in with the heroin, all kinds of problems. And so again, these changes in behavior can help to prevent the untoward outcomes if you can get in there and initiate things early, if possible, right? And so a lot of the health promotion efforts we'll talk about are going to really heavily depend on behavior modification, because while that is difficult to do, it is relatively cheap to do. You can get a lot of bang for your buck by telling people about the negative effects of smoking to try to change their behavior than trying to initiate things like lung cancer screenings and things like that. Looking at environmental factors, we can see here that whenever there's like an outbreak of a new disease, typically epidemiologists are the first ones sort of dispatched to find out what's going on. And so, if it's at the state level, you might have the Department of Health arrive first. If it's an interstate sort of thing, you may have the CDC here. But basically, they can go in and look at the environmental factors to see what may be playing a role. So, for instance, when you think about Legionnaire's disease or Legionella pneumophilia, you think about, well, why do they call it Legionnaire's disease? You probably know this already, but it has to do with an American Legion conference that was back in Philadelphia in the 70s. And basically, they had all these American Legion conference attendees coming down with the same disease state, the same pneumonia. And they're like, well, this is too odd of an occurrence to be due just to chance. There's got to be something here. And they were eventually able to link it back to the air conditioning unit, which is why for every single test you ever have, if it talks about an air conditioning unit, it's probably going to be Legionnaire's disease 9 times out of 10, I had to tell you. Looking at immunologic factors, certainly this can include things like if the host immune system is depressed due to things like corticosteroids, chemotherapy, genetics, but also think about things like vaccination status, right? Do vaccines always provide permanent immunity? Frequently they don't, right? Sometimes you need booster shots. Sometimes the disease changes to where you need a new vaccination, like the flu. You have to have a new flu vaccine every single year because the virus changes, right? And so this goes into the immunologic factors in terms of how susceptible a patient may be to a given disease. Nutritional factors can certainly play a role here as well. There's kind of an interesting study that was done here by this physician named Dennis Burkitt, and he was looking at the role of dietary fiber on good health. And I always find this kind of interesting because he was talking about between different countries, and I think mainly he was talking about places like Africa and then in the U.S. And he was saying by world standards, the entire U.S. population is constipated. And you can't diagnose appendicitis in Africa unless the patient speaks English, right? A lot of this has to do with the nutritional habits of people who are coming from the US, where we get a relatively small amount of fiber as compared to those over in other countries, for instance. And so in this case here, he also said, populations with large stools have small hospitals. Those with small stools have large hospitals. So kind of goes to show you, looking at the different factors there in terms of nutritional status and things like that. And so, even if you took patients who have African American patients who have that heritage, you can see it's not a genetic factor because as soon as you introduce them to the U.S. diet, all of a sudden they got constipated too. And if you go into any sort of pediatric ER, anyone with belly pain for the most part is probably going to be constipated, right? I'll never forget one time my cousin called me up and his daughter was like 4 at the time, I think. And I could hear her crying in the background. He's rushing off to the ER and he goes, I need to know if she's going to be okay. She's got the worst stomach pain she's ever had. She's crying. Is she going to be all right? And I go, she's constipated. He goes, no, she can't be constipated. This hurts too bad for that. And I go, okay, well, she's probably constipated, but you can take her in anyway. Sure enough, he calls me back 3 hours later and is like, how'd you know? And I go, because I've seen a heck of a lot of it, right? Sure enough, she was FOS. She was full of stool, right? Anyway, point being, eat your fiber, please. We also see there's plenty of genetic factors that may predispose certain patients to disease or may actually even be protective in certain cases there. And so when looking at things like genetic epidemiology, we know that mutation rates tend to stay pretty consistent throughout time. And we like to see kind of what that genetic shift is. Maybe we have new patient populations who are immigrating into a group to maybe affecting their genetics over time. And so it's kind of interesting to see those shifts and how you may be able to promote disease or actually protect against it based off of these genetic changes over time, right? So for instance, we can also do a lot of things like screening based on some of the more common genetic things that may directly affect, potentially a fetus, for instance. So for things like phenylketonuria, and for a lot of genetic disorders in Florida especially, we do screenings. We do certain screenings to make sure that a patient does not have CF or PKU or things like that. That way we can identify them early, because otherwise it can be quite harmful to the patient there, right? And so also, I don't know if maybe some of you have taken like your 23andMe test or something like that to find out if you carry certain genes that may be problematic or may affect things like, metabolism of caffeine. I've heard that's commonly on those before. I recall before I had my first kid, we actually had genetic testing done to see if we carried anything. Me and my wife carried anything that might be high risk. And actually one of us carries an autosomal recessive gene for a disease called SMA, or spinal muscular atrophy. Now, it's not a problem for either two of us because we only have one copy, so it really wouldn't potentially affect our children, but it's nice to know that we can let them know. They may want to be tested too one day to see if them or their partner may share those genes and could potentially affect a child. So little things like that are important from a genetic standpoint. Also, you can look at things like risk for MI, you can look for risk for certain types of cancer, all of that as related to their genetic factors. And this is where screening has become even easier. And that's why we have a lot of like home test kits now that you can even do. Just send off a saliva sample, and all of a sudden you know exactly who your dad is, or maybe who you thought your dad was is not really your dad, perhaps. Who knows? I've heard of stories like that. Anyway, so then the final one here being services, social, and spiritual factors, kind of a hodgepodge of things here. But you can see how, again, this kind of feeds somewhat back into the behavioral standpoint, but we like to kind of cordon them off because they can be distinct in some cases there. Now, again, when we say medical care, that's kind of what we're referring to as services. And you think, okay, well, the more medical care you have, the better off you're going to be, right? But unfortunately, you tend to see that, and just like I've mentioned before, being in the hospital is frequently one of the worst places to get better because medical errors can be somewhat common. You can have things like infections that occur in the hospital. All kinds of bad things can happen there. So that's why I always say get your patients out if you can, quickly as you can, because it's going to help to reduce risk for a lot of these bad things happening here. From a social and spiritual factor, here's kind of an interesting one. Looking at certain connections between health and disease in patients of certain religious backgrounds. So, for instance, if you were to look at Mormons and Seventh-day Adventists, which, we have a big hospital system here that is Adventist-based in town, you can see they actually have lower rates of a lot of metabolic diseases like heart disease, even some respiratory disorders, and cancer. And so you say, well, why would these patients of this particular spirituality have less risk for these disease states? And then if you go back to look at what their behaviors are, you can see that they try to prevent things like excessive alcohol use, or even any alcohol use, tobacco use, and even that things like their diet is very different. They try to, some of them will promote a more healthful diet, maybe even a vegetarian diet. And so by doing things like that, that directly affects their behavior, unless you can see these sorts of trends in a larger sort of spiritual group, right? Kind of interesting. So we also will talk about vaccination and things like that throughout the course here. And so one of the things, you'll may be hearing about is this idea of herd immunity, right? And how well that's able to protect us. And of course, what is herd immunity? Well, it's, basically having enough people who are protected from a disease or who are not susceptible to it. And that prevents people who are unprotected from actually getting the disease in and of itself, right? And so I'm sure most of you have a general idea of what this means, but in more specific terms, looking at it, you can see that, as disease progresses on, as one person passes off to two people, they can then pass off to two people, and so on and so forth, which is why you tend to see exponential growth of a new disease in a population that is not very well protected. And you'll see that as more and more people become protected, either immune from exposure or immune from a vaccine or something else, you tend to see that even those people who are not protected tend to be more generally free from disease because other people around them don't have it that could give it to them, essentially, right? So if you look at this example here, here's the absence of herd immunity versus presence of just 50%, right? So not even that big of a penetration of immunity there. You can see with no herd immunity, this person passes it to 2, and they pass it on to 2, they pass it on to 2, and you sort of get this exponential sort of growth there. I guess I don't know technically if it's exponential, but I'm going to call it that for now because it sounds better. But what if we had just 50% herd immunity? Just 50% of the people were not susceptible either due to genetics or, vaccine or whatever the case may be. So this one person would only pass it on to a single individual, whereas this person would be protected, so they would stay negative. And then they could not pass it on to anyone else. So all these people stay negative. And then this person can only pass it off to 50% of people they come in contact with. And so you can see overall, the majority of people are negative here, even though we only had 50% herd immunity. Less than 50% of the people here are actually infected. So again, that could be a useful strategy either through exposure or vaccination or whatever reason it is. And this helps to protect people who may be contraindicated from something like a vaccine, for instance, right? So it can be a very helpful thing for patients. Now, looking at the degree of immunity, it really can affect things like vaccination patterns, how we dose vaccinations, are vaccinations even reasonable, how often we have to give them, and etc. And so, for instance, when we're looking at the degree of immunity needed to get a virus out of a population, that can depend on the type of virus, influenza, coronavirus, time of year, right? So we're going to see certainly spikes in flu during the wintertime months here, and also the density and social patterns of the population. Pretty interesting, huh? But especially like in the winter months and places where it's more cold, what do people like to do? Do they go outside a lot? Not really. They'll bundle up inside, and that leads to more close contacts, and that can lead to more disease spread. I remember when I was interviewing for a position at one time when I was coming out of fellowship, I interviewed for a position in it was the Mayo Clinic up in Minnesota, and I think it was February when I interviewed. And I got off the plane and I said, "Nope, this is not the job for me." I was still polite and went through the interview, but I realized that that kind of cold environment not great for me, right? But that's the kind of place where you stay inside a lot during the winter months, and that increases the spread of some of these diseases. Okay. Now, it may seem like, okay, well, let's just immunize everybody during childhood, and there's going to be no problems left, right? We're going to get rid of all these diseases, right? Well, not really the case. You're going to see that not every vaccine is perfect, right? And so I'm certainly of the belief that vaccines do work, but we have to realize their limitations. So here's an example of a vaccine against diphtheria. And we saw that vaccine, while producing immunity in individuals who get it, they do tend to decrease that immunity over time. And again, there's something we'll talk about in Pharm next semester, but we'll talk about this sort of immunologic memory. How long does your body keep the memory of that immunization before it starts to lose it and the patient becomes susceptible again? So here's an example where when diphtheria was more common of a disease, now everyone still gets vaccinated for it, but people who had been vaccinated against it were exposed more frequently to the causative agent, and this exposure could result in mild reinfection, right? So basically it means you got vaccinated as a kid, but that was the last dose you ever got. And then as you got re-exposed to people because the disease was more prevalent, you got that booster effect. Well, nowadays you don't really see a lot of diphtheria, and so we don't really have that natural booster that you'd normally run into. And so because of that, we have to basically give artificial boosters, which is why, you'll have patients who will get the TD shot, which is tetanus and diphtheria, in order to reinvigorate their immune system and to help to strengthen that immunity, right? So as I mentioned, when the disease became less common, there were fewer people who were exposed and thus less of those little subclinical booster infections patients would get, right? And so here's an example back in Russia where even though the diphtheria vaccine was commonly used in children, what you found is that over time, many adults became susceptible. They actually had a major epidemic that popped up in the 90s here, and they had about 72% of reported cases were older than 14 years of age. So kids were protected. It was just as time went on and they lost that immunity and they weren't really exposed to a lot of people, they were more likely to actually contract the disease and then give that severe disease to other people. And then you saw this epidemic that actually occurred there, right? And so again, it wasn't due to the fact that kids weren't being immunized. I mean, more than 90% were. It was just the fact that they lost this decline of immunity levels over time and they never got the booster effect. And so again, by the time they actually got everything under control, there's like 4,000 deaths that had occurred there and 125,000 cases. So again, very significant epidemic, although now looking at the numbers, it kind of pales in comparison to what we're looking at nowadays for sure. But other things too, other factors that go into this. So for instance, like sanitation can be a big thing that can affect disease. And so here's kind of an interesting thing where you think sanitation is good, right? Keep people from getting sick, people are cleaner, everything's great. However, you may actually find that there are some drawbacks to that. There's kind of a double-edged sword. So here's my platform to talk about, the use of just once weekly showers. I think that's really the best way to do. I'm just kidding, don't do that. But anyway, looking at this in the 19th century, they found that diarrheal diseases was a huge killer of kids. And then for adults, it was mainly TB that was the major killer, right? And again, people didn't realize that you needed to do things like wash your hands and prevent fecal oral transfer and things like that. And then they had this thing called the Sanitary Revolution in England, right? And basically, they found that this was a huge impact to help reduce infant mortality rate. A lot of these kids were living through the infant period to become full adults. And so because you have this big reduction in infant mortality, guess what happens with the population? Well, those kids grow into adults and then tend to procreate and produce more kids who are also living for longer. And so you get this explosion in population growth. And though what you find is that when infant mortality rate's high, families tend to have a large number of kids to make sure that at least one or two of them survive into adulthood. But when you live in a place where infant mortality is relatively low, like most developed countries nowadays, you don't have to do that. You only have to have one or two kids, and then you're reasonably well assured they're probably going to survive to be able to then procreate later on. So it's kind of interesting. So having extra sanitation, you have this big population growth, but can that environment support that? Can you support those extra people? And so that's a big concern in a lot of places in the world, which is interesting. Okay. So what are also some contributions that epidemiologists have to medical science, right? And so epidemiologists, as I mentioned, are sort of the initial detectives that investigate something to try to find out kind of what's going on, what, can we come up with a way to screen for this? Can we diagnose it? Can we come up with a means of prevention and or treatment? And we give you some examples of how epidemiologists have helped out with that. And so you can find that they have been able to come up with the type of agent, the modes of transmission for a ton of diseases over the past 30 years or so, and even longer than that. But it's certainly been exploding and becoming more common as time goes on. And so, looking at this, we can see, the first identified cases of a new disease, they frequently are going to be one of those things where they're often really fatal or severe. Basically, we're going to look at this as sort of like an iceberg sort of phenomenon where when a disease is brand new, we don't really know much about it. And so we only really detect the cases that are going to be sort of most notable, meaning they get really sick or they die, right? And so that's usually the first clue that, hey, something weird's going on here. We probably need to investigate this a little bit further. And so then as the disease becomes more known, then we can now start to identify less severe and even asymptomatic individuals, right? So remember back in the day, meaning March, we didn't have a really good way to test a lot of individuals to see who has COVID. But nowadays, we have much more readily available testing measures. We can find and identify asymptomatic individuals who have disease, right? Who have COVID-19. As a good example of this, when COVID first hit, we basically at Nemours, we shut down all surgery, all elective surgeries, couldn't do them because we didn't have a means of making sure that we protect patients to make sure they don't have COVID. That way, healthcare providers don't give it to them, and the patients couldn't give it to us. And so they shut all that down, right? Until they were able to come up with better ways to be able to identify asymptomatic individuals more readily. And then now they can just test every patient coming in and perform surgery again, right? So we see big changes here, even in the current day as a result of this stuff, okay? So anyway, so when looking at infectious diseases, as I mentioned, those asymptomatic people tend to be either uncovered by looking for things like antibody titers, to the organism, which we can find nowadays, or by culturing the organism from them, which may be more applicable if you're dealing with something like bacterial, for instance. And what we're going to find is that variation of disease in basically how severe patients get in terms of illness is called the biologic spectrum of disease, otherwise known as the iceberg phenomenon, as I mentioned here. So for instance, when you have a disease first coming out onto the global scene, you see just a few deaths here. These are the most severe cases. And maybe you pick up a few of these clinical illnesses here. This is what we know about. But certainly there's always going to be some degree of asymptomatic infection going on, and that's what we want to be able to identify. And again, you've seen over the past 6 months or so that we've gotten better at being able to do that, to find those people who are kind of underneath the surface, so to speak. Surveillance is a huge part of epidemiologists' job as well. We like to look for trends and things. We like to look at the data to see if there's spikes in certain things occurring there. We actually do a lot of this at the Poison Center, where we can do real-time collection and monitoring of calls coming in for various things, right? So we can actually look at things like food poisoning that people are calling in. We can look at, for instance, when we had, I don't know if you guys remember the big oil spill that happened a couple years ago. I guess it's longer than that now. It's probably close to like 8-10 years ago, that occurred off on the Gulf Coast. The whole Florida coast was generally affected. Yeah, the BP oil spill. Thank you. The whole Florida coast basically was affected there. And we had patients calling in. I think it was Deepwater Horizon, right? But we had all these people who were calling in that had exposure to this oil, and we could see where the exposures were happening at. We could look to see numbers. We can look to see basically where the stuff was occurring at, and that can give us a really good idea of where to go to do investigations. We coordinate with the Department of Health pretty intensely, and so we would send this information along, and then they could follow up and try to find where exposures were happening at, if they could do any sort of preventative measures, do they need to close beaches, all kinds of stuff like that. So again, this is a very data-driven sort of thing here. Here's one example where they actually did a large-scale field trial for this inactivated polio vaccine. Again, this is back in the 50s. So again, they wanted to confirm, they thought that, yeah, this vaccine was very safe, very effective, and we want to put it out onto the market. And recall, drug trials typically don't include millions of people. It's only probably thousands, right? And so one of the things they would look at was they have this polio surveillance program. A lot of what the CDC does is just surveillance for disease to see if they're noticing epidemic increases in incidence of cases, right? And so what they actually found was that there was a outbreak of these vaccine-associated poliomyelitis, and that's really weird. They found these new cases of polio, and they wanted to go back to see, well, what was the link here? And they found these patients that all received this vaccine in question. And so what they actually found was when they went back to the company, there was a slight change in the procedure of producing it. And instead of producing sort of an activated virus, they had a live virus. And so this was actually giving people the infection in question. And so then by recognizing that and being able to look at the surveillance data, they could then remove it from the market immediately. Okay. And usually these things happen pretty quickly. Just like when they were looking at the drug ranitidine, and that's drugs we've been using for decades, and it's always been a really good H2 blocker. We realized all of a sudden that there was a carcinogen that could be developed in it if exposed to heat, and very quickly that drug is now removed off the market. We may never see its use again, which is a shame because it was a good drug, but now we got alternatives we can use instead. But again, it goes back to ultimately looking for the health and safety of the patients, right? We can also look at like disease control priorities. This is also a really important thing too, which is kind of interesting, where diseases sort of taking the spotlight get a whole lot of attention. They get a whole lot of money thrown their way, and then once it kind of dies down a little bit, people tend to forget about it, right? People have a very limited attention span, as it turns out, and you can see here that like especially like in the U.S., like legislatures are the people funding these control efforts, right? And they're looking to see, okay, well, which of these cases, which of these things, limited resources, how do we divvy them up? What do we focus on here? And they tend to focus on the things that are sort of in the news, or things that are very common all of a sudden, and things that people care about. And so as an example, here in the 50s, they had a sharp drop in the reported syphilis rates. And so they said, okay, well, syphilis must be under control. Let's go ahead and not necessarily fund these efforts anymore. Guess what happens? They get a subsequent rebound, right? Not only that, but you can have health funding that's influenced by money, by powerful people with a whole lot of money, which is really kind of interesting. Whether I watched a video recently on YouTube talking about, billionaires funding some of these health outreach programs in different countries, and whether that's necessarily the best use of their money. But because they're the one throwing the money around, they get to decide what the priorities are, right? Instead of it being maybe the people that live in that country, for instance. So certainly can go on a deep dive through that. But again, very interesting things. And again, ultimately, a lot of this comes back to money, unfortunately. Maybe we'll get to the Star Trek, a future where there is no more money, perhaps. We'll see. Actually, we're probably more heading toward like, Dawn of the Dead sort of situation there. But we'll see how 2020 ends. Regardless, here we can also see that we can do things like improving diagnosis and treatment of clinical disease here. So for instance, we can look at trying to develop new strategies to screen for diseases, right? So finding the best way to set cutoff points for different diagnostic tests. Actually, this is a good point here. When we were looking at that study just yesterday, and they were looking at the glenohumeral, whatever that distance was. Obviously, I remember it so well, but they could use that as a cutoff point. So that way, if someone doing ultrasound found a certain distance, they could say, yeah, this is probably a dislocation, right? That's part of epidemiology too, trying to find right cutoff points for diagnostic tests to say whether something is positive or negative, and maybe whether people need further screening or not, as the case may be. And so we can also do things like trying to do risk estimation. So I'm sure a lot of you have heard of the Framingham Heart Study, and this is a huge study being done for decades and decades that's been looking at various cardiac risk factors, right? They take this data and try to figure out, well, what puts patient at risk for cardiac disease, and then how can we extrapolate that out to the rest of the US, for instance? So we know that if you smoke, you're more likely to have a heart attack. If you are obese, you're more likely to have a heart attack. All that is risk estimations provided by some of these larger ongoing epidemiologic studies, right? So anyway, so that's it for the first section here. Kind of dipping your toes in a little bit, hopefully wetting your whistle a tad to see if to get you more interested in what's to come. Now I want to get into sort of the nitty gritty of things here. Let's see if there's any questions. Oh, there are questions. Fantastic. Someone says, for this exam, would you like us to know specific cases, examples, or people? You should know me. I'll probably show up on the exam. I'm just kidding. No, I will give you cases though on the test. So very similar to what the biostatistics section was. I'll give you examples of things. I'll give you a little vignette, and you'll be able to take away certain points away from that, and that's what the questions will be about. You'll be able to make determinations or assessments based off of a vignette, but I won't ask you specifics like the Salk IPV vaccine. I probably would not ask about that specifically, right? I talk about genetic testing. Is there certain tests that are better than others? That depends on what you're referring to. I'm assuming you're talking about like the 23andMe and stuff like that. I don't know enough about that to be able to vouch for one or the other. I honestly don't remember which one I took back in the day. I think my wife just said, here, spit on this, and then I went ahead and gave it over to her, and that was it. I generally try to do what she says. So no, I do not know which one's better than others, but you may want to look at it to see what they're testing for specifically. So I know some of them are looking at like your genetic lineage, seeing like where your ancestors came from. Some of them more focus on different health outcomes. Like they can look at things like certain drug metabolism interactions. They can test to see if you're like a slow metabolizer or a fast metabolizer or certain things. So all that depends on kind of what you are interested in. Anyway, let me pull up part 2 or number 12 here. So Jackson's saying, I just paid some dude out of the side of a Walmart and he swabbed my cheek. I'm still waiting on the results. Well, hopefully it comes back positive or negative, whatever you're looking for. I think of the last dude that swabbed my cheek at the side of a Walmart. Those Palaca Walmarts are just something else if you're familiar with the area. Just kidding. Okay, so let's kind of get into sort of the nitty gritty. Let's start to talk about how we actually measure and look at risk and rates of disease and prevalence and incidence. We're getting all into sort of the definitions and things we need to know in order to kind of talk about these studies and whatnot more specifically. So I won't finish this section today, but this is a pretty spicy one here. Lots of good information that you do want to know for the future, particularly the test. So anyway, so let's look at like where do we get sources of health data? Like, where do we like find out like where disease is happening at? Where do we find out, how many people are at risk for a certain thing? Oh my goodness, I'm so sorry. I'm already on the slide now. Thank you for reminding me. So this is why I'm not going to be a professional streamer anytime soon. I can't even get my transitions correct. But anyway, so, where do we find out like what our denominator is, what our numerator is? How do I know how many people are at risk for a disease happening? We have resources. We have different databases and things like that available that help us out with that. So for instance, when I want to know the number of people at risk for a disease state, I can use things like census statistics as my denominator, right? If I want to know how many people live in Florida currently, we have means of tracking that sort of thing. And that can be helpful because I can know how many people are at risk for getting COVID. Well, anyone in Florida might be at risk for getting it, for instance. And then the numerator data tends to be defined by the events or the condition that I'm concerned with. So if I'm looking at death, for instance, I may want to look at the coroner's office or the medical examiner's office. That's an important distinction, actually, to look for things like death registries. I don't know if you guys know this, but in Florida, we have medical examiners, which are actually pathology trained MDs and DOs, right? Versus if you go to some other states, they just have coroners, which is, you can just get like a certificate to be a coroner, and it doesn't have to be any kind of medical professional. And these are people that are calling causes of death and things like that. So it's actually a really interesting thing here. If you've ever heard of Dr. G Medical Examiner, that was here in Orange County. And one time I was able to go and visit their offices and talk with one of their medical examiners. It's really fascinating, really cool stuff. Let me talk about that later if you get a chance. Anyway, but we can collect data like different disease states that have been reported. We can collect things like birth. If you ever want to find out like what are the rates of different types of like drug overdoses in Florida, we have means of doing that. We can actually look at live statistics to see like how many cases of opioid overdoses have occurred over a certain time frame, right? See if I can find this real quick. I think it's kind of so just so I can give you an example what like a real-time set of data actually looks like. We can see here, this is data pulling just from Florida Poison Center across, we have 3 different centers here in Florida, but you can see things like looking at, okay, well, who contacts us? Like what are the age of patients that are frequently calling in for poisonings? Or you can look to see what type of substances have people been exposed to. And you notice here benzodiazepines, which are anxiolytic drugs, ibuprofen, ethanol. You can find real-time data, which is like super cool that we have the ability to do that. So just as an example, this is a database you could use as numerator data for your stuff, right? I could probably play with that all day long and just find whatnot. But again, we have very sophisticated data means, and again, this has been decades in the making. Like, it certainly wasn't like this back in the late 80s and 90s when the poison centers first started. But anyway, so you can find all kinds of information depending on the data you have available to you. And so in terms of like census data, this is normally something done every 10 years. And again, this is a census year happening right now. It's usually every year that ends with the 0. And again, this is why it's so important for people to fill out the census, because we can't count people if they're not listed. They don't turn that in. And that can affect things like your denominator data there, which is really important. We can also find, different reporting systems. For instance, like every birth that happens, it gets reported out through into the birth registry, essentially. And so, there can be downsides to these in terms of like actually collecting all the data, because maybe if someone is born at home, they don't get captured here. But again, these are the best systems that we have available to us to determine who's being born, who's dying, how many people are in a given location, and all of that. Again, this is the U.S. Vital Statistics System that helps us out with that. And again, they're basically the federal branch that helps to collate all this data here, trying to find out, when people are born, how many people are born, what was their cause of death, right? There's actually been a bit of a controversy around patients who have died with COVID infections. Did they die of pneumonia, or was it COVID? Was it a combination of the two? Who could say, right? How do these people get counted? So again, as we get new diseases, we're always finding out new things. We're learning how to count these things differently. Even marriages and divorces get included with that. If you recall, the study that I used to help my wife make the decision to move in with me, which I ultimately think was a good decision, was from the CDC, right? Again, this is something that's the federal government, basically. So, and again, the analyses are only as good as the data they have. So if you're working with bum data, it's garbage in, garbage out. So as long as you have the best data possible, you're gonna be able to make the most accurate representations of that data and the most accurate interpretations. And so there's a lot of sources of error, right? So I mentioned unreported births and deaths, right? I have several children who I don't know if they've ever been reported out. They're certainly not in this state, so I don't know if they got counted or not. Just kidding. What if you have an inaccurate death certificate diagnosis? That kind of goes back to that, coroner versus medical examiner. Someone with a medical background might be able to make a more specific and correct diagnosis than someone with no medical background, right? You say someone dies in a car crash, and the coroner may say, no, not just to dunk on coroners, but that's basically what the medical examiner was. That was her perspective when she told me about it. But basically, they can say, okay, this person died from a motor vehicle accident. Whereas the medical examiner may say, well, actually, they died of a heart attack while they were driving, and then that's how they died, for instance. So inaccurate information there can be problematic. If you have erroneous demographic or clinical data, things like that can all affect things. And again, we have also means of collecting data on certain disease states. And so I think we talked about this briefly before about collecting data on, or like mandatory reporting for different disease states. And so this is the National Notifiable Disease Surveillance System. This is run by the CDC up in Atlanta. If you're not familiar, just watch the first season of Walking Dead. You'll certainly know that. And again, what we'll find is that if you're working in a hospital and you have a new case of Ebola, for instance, hopefully don't run into that, but you would report that to the Department of Health for the state, whatever state you're working in, and then that gets reported up to the CDC. Okay, again, all the information funnels up, so that way, if there is an outbreak or if there's an epidemic of something, that information can then be disseminated out to find out what's going on. So for instance, when we, if you guys recall bath salts, I don't know if you guys recall that or not, hopefully no one partook of any bath salts, but I remember I was working in the poison center. I was actually answering phone calls during my fellowship when I had this call for this thing, and they said, oh yeah, it's this stuff called white lightning. And I was like, what the heck is that? And they told me the chemical that was listed on the product there. And I was like, I've never heard of that before. I looked it up, and there's almost no information that's out there. Yes, famously, they talk about the guy who ate the other guy's face off. Actually, that man never had any identifiable bath salts found in his system. Not to say he didn't have anything else in his system, but not the common ones. But regardless, I remember getting that call and be like, we don't have any information about this. What's going on? And so again, by reporting that data up, we were able to then find there's kind of a rash of these things popping up in Florida, and we could then send out a health kind of notice to hospitals and physicians and things like that to say, hey, be on the lookout for this stuff. If this occurs, if exposure happens, this is what you want to look for. They're going to come in tachycardic, they might have seizures, they're hyperthermic, and all these things here, and how you manage. Again, very helpful. Yeah, I believe that was down in Miami, but very helpful in order to make sure that we disseminate information so that other providers who may not have seen it yet are prepared for it, right? Because preparation is, 9/10 of the battle there. So here's just an example of different disease states that are considered mandatory reporting. So on an exam, I could ask for any one of these. So I'd probably just start memorizing them now. Just kidding. I'm not going to have you memorize any of this stuff. But just to give an example of the different varieties of disease states, and there's a lot of them here, right? Now, if you're working, do you think that you're going to be able to remember all of these to report out in case you run into one of them? Probably not, right? And so that means that only a fraction of the actual cases really get reported out, which means that typically we're going to be finding that we get underdiagnosis. Now, if you go back to this list, if you found a case of a patient with botulism, or perhaps if they had, let's see, where's another case here? Something like Ebola, you would probably be pretty likely to report that out because that's a very unusual thing. Maybe the patients are very sick. You definitely want people to know about that, right? But what if you run into a case of a person with syphilis, right? You may not think about that necessarily, right? Because you may run into syphilis quite frequently, depending on where you work and what. Obviously, you might not run into that if you're working like in a derm office, but if you're in the ER, you might see it pretty regularly. So because of that, you may have a lot of underdiagnosis of diseases here. So Shelby's saying they should have something in the EMR that pops up if we need to report it. That's correct, but also on the background, you may not have to because there may be, especially with like ICD-10 codes and things like that, they can have automatic reporting things set up in the background, so that way you don't even have to think about it as a provider, right? So that way you can see, okay, we had this many cases of syphilis that get reported out here. We're going to go ahead and just send this data up to the Department of Health, right? It may not be national news by any means, but it's still good to be able to track that stuff. And so the other thing too is, like, as a provider, if you were going to be doing manual reporting, say you're working in a smaller area where they don't have those capabilities, that's something where you may be cautious to do that, right? Maybe you don't want to blow up someone's case because they have HIV, for instance, right? There could be ramifications for that if the health department calls them up the next day to follow up with them, for instance. And so there could be cases where people are not likely to report these things. So overall, things get underdiagnosed. Doesn't mean that it's not useful, though, right? And so one of the things you'll see here, as long as the cases that are being reported, as long as those rates remain somewhat constant, the pattern is still useful. Okay, so even though if I'm not getting every single case of syphilis being reported out, as long as things are being somewhat stable, I'm not too worried about things. But if I all of a sudden see a certain spike in it, then I probably know that spike is even bigger than what's being reported, and you can still be able to act on that, right? So even if you don't have the best data, you can still make some assertions there. Okay. Moving into next are epidemiologic measurements. So let's talk about frequency. Like, how do we count frequency of things happening, right? And when I'm talking about frequency, it's basically how often a disease, an injury, a death, whatever sort of outcome I want to measure is happening. And the ways that we can talk about that and describe it in a population or in a sample is important to understand. So we're going to get into a few cases of that. These terms I've been using all throughout the course. You may not have necessarily known specifically what I was talking about, but we're going to be more specific here. So first thing here is going to be incidence. Incidence is the frequency of new occurrences of the outcome I'm interested in during a study period. Okay, so if a patient transitions from well to ill, from uninjured to injured, or from alive to dead, whatever the case may be, they are now an incident case. Okay, so if I follow 200 people for 1 year and 10 of them die, the incidence of death is 10 people out of 200, or 5%. So like I say, there's a 5% incidence of death in this sample for 1 year. Okay. On the flip side of that, there is prevalence, this is typically called point prevalence we're talking about. This is basically if you take a sample or a population and you took one slice in time, said today, this hour, how many people have the outcome of question? That's going to be the prevalence, right? So if I survey 500 people, I call 500 people up on a day. Actually, I don't like calling people. If I had 500 people fill out an internet survey in 1 day, and I found that 150 of them have hypertension that very day, then the prevalence is 150 out of 500, or 30% prevalence of hypertension. Okay. There's another term we're going to use here in a little bit called period prevalence, and this is going to be the number of cases during a specified time. I'm glad I have a pop filter on my microphone, because otherwise this period prevalence would probably be spiking in your ears right now. Okay. So there's some ways we can illustrate this idea of morbidity concepts here. And so I'm going to be showing you a graph here in just a moment that kind of illustrates some of these points here. And we can look at things like incidence, point prevalence, and period prevalence based off the data we're about to look at. And so we're basically going to be looking at 8 people, and we're looking at one specific disease state. And we're basically going to be looking at them over a period of time. So T1 is going to be the initial time, and T2 is going to be the final time there. And we're going to see when people become sick, when they either recover or die, and we can use that to help us determine what the incidence is, prevalence, and all of that. So here is the picture I'm showing you. So if someone already has the line started at T1, that means they entered the study with the disease state already in question, okay? If the line starts in the middle of the time period, that means that they developed the disease during the study period. In this case here, it's a year. If their line ends at the during the study period, that means they either recovered or they died. Okay, and then if the line continues past T2, the end of the time period, that means they ended the study with the disease still occurring. They still have the disease in question. They never recovered or died. Okay, so let's look at how we can illustrate some of these different points that we've been talking about based on this information here. So if you look at case number 1, they were a person who started the study with the disease in question, and they ended the study with the disease in question. They never actually recovered, okay? They were alive when it started, they were alive when it ended, but they still had the disease. You look at cases 2, 6, and 8, so 2 right here, look at case 6 here, and then case 8. They all entered the study with the disease in question, but they ultimately either recovered or died by the end of it, as you can see here, 2, 6, and 8. So the line started at T1 and it ended sometime before T2 did. Okay. Numbers 3 and 5, they became ill during the year, but they were still alive and well when the year ended. So you can see here 3 and 5, they started at different times, but they all ended up at T2 with the disease still in question. Okay, but they're still alive. And then finally 4 and 7, they became ill during the year and they then recovered and or died during the year. So you see 4 here, they starts and ends between T1 and T2, along with number 7 that does that. Okay, so you're like, okay, well, why do I care about this stuff? Well, because we can illustrate the different points we're talking about. So based off of this, we can do a few different calculations. And again, this is not really calculations, it's more just like counting things, which I guess is a very easy form of calculation. But looking at this, so if we wanted to find out the incident cases during the year, right? So the number of new cases that happened during the year, we can count that. We can see the number of new lines that started. So 3, 4, 5, and 7. So I could say over the course of this year, there were 4 incident cases, okay? Or maybe even you could say 50% incidence of new onset of this illness because there's 8 patients in total. I could look at point prevalence at specific times. So I could look at T1 at the very beginning of the time and count how many people already have the disease state at that very one particular slice and tell you the point prevalence. So at T1, I can say there's 1, 2, 3, and 4. The prevalence of disease at T1 is 4 out of 8 or 50%. I could also look at point prevalence at the end as well. I can say here, who has the disease at the end at point or T2? I can say 1, say 2, and 3. So there's 3 out of 8 at that point is the point prevalence there. Okay. So looking at that, you can get some ideas in terms of how to calculate incidence, how to determine prevalence at various time points. It's basically just counting. It's pretty straightforward there. Okay. And again, people can be considered prevalent cases at many different time points. So again, if I can put that slice anywhere, and I can get different numbers of incident cases too. It's prevalent cases at different points here. So if I went ahead and did a slice right through the middle here, I'd have 1, 2, 3, 4, 5, and 6 prevalent cases. Okay, so just have an idea of how to count that and how to come up with incidence and prevalence based off what we're looking at here. We'll get a little more complicated, and we'll look at that now. So, and again, I'm sorry this class might be a bit of a bummer, but you know, we're dealing a lot with death and things like that, so it kind of is what it is. But here is a graph here showing the reported cases of AIDS and then looking at it over the course of time. And if you recall, AIDS is really a disease that started in the 80s, right? I'm sure you guys watched In the Band Played On as part of your cultural issues class. Very good movie kind of illustrating sort of the early days of the AIDS epidemic, right? Again, it was an epidemic because it was a brand new disease we'd never really seen before. So what this graph is basically showing us is showing us incident cases during each of these given years here. And then we can also figure out what the prevalence of disease is at the end of the time frame, which is going to be 1992 here. I'm going to show you how that works out. So you can see our N here is going to be 253,000 people. We can see the time frame is on the x-axis here, and then we see the reported cases of AIDS on the y-axis here. Okay, so also notice the two colors of the bars. If the bar is gray, that means they were dead at the end of the study period, and if the bar is white, it means they were alive at the end of the study period. So at the end of 1992, all the people that are gray here were dead, and all the people that were white here are still alive. Okay. So what does that tell us? Well, one, we can look at the incident cases per year. And so what do you notice? Well, the incident cases keeps going up and up and up and up and up. And we can investigate why that is. Well, maybe it's because initially we were only looking at the most severe cases. We're only finding the people that had really severe immunosuppression, dying from these infections. And we really only found them really early on. We didn't see a lot of the asymptomatic people yet. But as we got better at being able to recognize it, we saw that we had more and more people that actually had the disease state. Doesn't mean that there weren't more than just these few people here with the disease, just means we didn't detect them yet. So we just see the incidence kept going up and up and up, the highest incidence being in 1992 at this point, okay? What's interesting though is like when you actually look at the cumulative prevalence at the very end here, which is basically if you add up all the white bars here, you can get what the total prevalence was at the very end of the time period. But what do you notice about the people who got diagnosed early versus the people who diagnosed late? Well, you start to notice there's not very many of these people alive, right? And so this is another factor too, is you have to think about how long have people lived with this disease. The longer you live with it, the more likely you are to perhaps have died from it, right? Or the earlier you got diagnosed with it, the more likely you were to have died from it, especially if you got it very early on, because again, there were not a whole lot of treatments. We're going to look at some of the factors that fit into that, but what you can notice here is if you got diagnosed very late in 1992, there was a very high likelihood you were still alive, more than half. Okay, versus if you got diagnosed in 1981, very unlikely to have anyone alive left. Okay, so this slide kind of shows specifically what we were talking about on the last slide here. It kind of summarizes that, so that way in case you missed anything, you can go back and look at that. Just remember that all the white bars added together would be the prevalence at the end of 1992. That's what that basically is telling us. Okay. Now, again, what you were to find is that people diagnosed between 90 and 92 are more likely to be alive at the cutoff date. And again, this is due to either recency of infection or due to improved treatment, right? Because it could be either or. They have not had the disease for very long, or they had access to better medications, for instance, okay? What they found was that almost all people who got diagnosed for 6 years had died, right? Because there was very little treatment. Maybe they'd had it for a longer period of time. And so again, that's really the tough thing with having some of these newer diseases. We don't have a whole lot to treat it with, right? We just don't know much about it. And so what you end up finding here as well is that the total number of cases of an epidemic disease reported over time is called the cumulative incidence. So if you added up every single one of these bars together, that would then be the cumulative incidence of AIDS during the time period. If you just count up all the white bars at the end, this is the prevalence at the end of the study period. Okay, so just some different ways we can talk about the data and describe it in terms of frequency. Now, what's kind of interesting too is that definitions make all of the difference. So in here, we found that in 1993, the CDC had made a major change to how they classify and what the criteria for defining AIDS were. And so what this did was actually suddenly expand the definition and led to a big spike in cases. And so it's really important to understand is when you have major changes in the diagnosis of a disease or in the treatment of a disease, anything like that, it can make it very difficult to compare pre and post because it's sort of turning into apples and oranges, right? So when you look here, you can see that from 87, you see the rates are going up, pretty consistently. And then 93 hits and it looks like, wow, what happened here? Did all of a sudden we have all these brand new cases of disease occur? Well, probably not. It just means that we are now capturing a heck of a lot more people than we were in the year previous because now they've expanded the definition, right? Just like with COVID, if you test for more people, especially those that are asymptomatic, if you do more routine testing, your case numbers are probably going to go up because you're catching a lot of those asymptomatic individuals, right? So this was probably catching a lot of people before they got sick enough to actually be diagnosed via the old ways, okay? So again, you always have to look at the way the data is collected, look at their definitions to make sense of it. Because again, if you just look at the numbers here, you're like, wow, AIDS got really, really infective all of a sudden, really got virulent and spreading to everyone. But it was a definition change. And so again, it's hard to compare this data back to the old data because again, definitions are all different. Okay. So again, prevalence can be the result of many different factors here. So we can see that it could be related to the number of new cases. So maybe that case number is going up or down perhaps. You can see that it could be due to immigration or immigration of persons with the disease. So immigration means people coming into a population. Immigration would be people leaving the population, right? So that can have an effect on the disease state. If you have a lot of people moving in who have it. So for instance, early on, as part of means of trying to head off COVID, a lot of travel restrictions were put in place because they were trying to limit the number of new cases. And so they limited immigration into many countries. A lot of countries did that, right? And then you have to look at the average duration of disease. So whether or not people either die or they recover, right? And so this is really kind of interesting because as people live longer with the disease, you can actually see that the prevalence increases even though the incidence of new cases goes down. I'll show you what that looks like in just a moment here. But looking at the formula for how we determine prevalence, and again, I'm not going to have you calculate this necessarily, but what the idea I want you to get is what are the factors that go into this, right? When you look at this, the prevalence means the number of new cases that you have times the average time that people live with it. It's important because if average duration goes up, prevalence is going to go up. Even if incidence goes down a little bit, the average duration goes up a lot, you'll see the prevalence actually increases, which is kind of interesting. So we'll see some examples of that. So again, you're going to find that the formula works best if the incidence of disease and the duration is stable for an extended period of time. So that means the prevalence should stay stable. But we're going to see that in the case of things like AIDS, that you can either see increases in the yearly number of new cases, or you can have an increase in the length of time that symptomatic people are surviving, right? Or perhaps that they're recovering, if that is a possibility. So for instance, nowadays we have much better antiretroviral therapy for patients with HIV and AIDS, and they live for much, much longer. They're still prevalent cases, but they're still alive, but it may not be as many incident cases due to other things like, prevention of spread of disease through, protection during sex, or, preventing IV drug abuse and things like that. They are major spreads for things like bloodborne diseases. So again, as I mentioned, the duration of life is increasing for these patients here, mainly due to better antiretroviral therapy, and also we have better therapy for opportunistic infections. So people are not dying from things like PJP pneumonia as much anymore because we have better means of preventing and treating it. And so because of that increased length of survival, you're going to have even though there's an increase in incidence, if the increase in survival outweighs the decline in incidence, you overall see the prevalence is going to go up. Okay. Or as another example here with cardiovascular disease, even though we've gotten better treatments, we have better means of getting people to the cath labs, and we have better drugs we're using for these patients here. What you can find is that patients can live longer with the diseases, so that the prevalence actually goes up, even though the incident cases tend to be declining in the U.S. in recent decades, right? Kind of interesting from that standpoint. I say these things are interesting. They are to me. I don't know if they are to you, so maybe it's a subjective finding on my part, but regardless. So let's talk about risk a little bit here. We've already mentioned risk before, but basically it's the proportion of people who are unaffected at the beginning of a study period, but who undergo the risk event during a study period. So as I mentioned, this risk event could be really anything you define, whatever outcome you want, whether it could be fracture, it could be death, it could be recovery, it could be lots of different things, however the researcher defines it here, right? And so any of the people that are at risk for an event are called a cohort. If you recall, we talked about cohort studies already. Now you can have two cohorts of people, one of which is exposed to a risk factor, one is not. And then you look to see how many people develop the outcome, right? Those are all cohorts. So again, if you have a defined denominator, you know the number of people are at risk. So if I put 100 people in a cohort, I follow them to see who dies, I know those 100 people are all at risk for dying, and thus I can determine what my risk is. So if I put 100 people into a cohort, 10 of them die, then I know there's a 10% risk of death during that time period, right? So when you're trying to apply risk estimates, which we typically derive from a population, it's difficult when you're trying to then apply that to a single individual, right? So you can look in a study and see, like, what's the risk of death from driving a car, for instance, and then tell that to a patient, and it may not really make them feel all that much better, right? So for instance here, if a bad outcome happens for a patient, it stops being a percentage chance. Instead, for them, it becomes they either had it or they didn't, right? So it's either 100% or 0% for them. So instead of, if someone comes up and you're about to, take them back to surgery or something, right? So you're about to take them back for, appendectomy, for instance, and say, what are my chances, Mr. and Mrs. PA, what are my chances of living here? And you can say, well, your chances are 99% you're going to survive. And that's not going to sound great to the patient, because there might be like, well, what if I'm the 1%? 1 out of 99? Like, that doesn't sound very good. What if I'm the one, right? Because everyone thinks they're special. Everyone's the main character of their own video game, so to speak. So sometimes it can be tough, right? Sometimes what we have to do is try to put things into context for them, right? We could try to compare the risk of death due to, laparoscopic appendectomy to something like driving a car, which would be much more dangerous overall if you looked at the percentages. And so this is why it's important not to just take the absolute clinical look and just say, oh, you have a 5% chance of death. Again, the message is important. How you convey that message can really matter, because you could really scare someone and undermine their trust in your abilities to take care of them, right? So frequently it's difficult to determine what the denominator is when you're trying to figure out risk too. Like, who is truly at risk for a given outcome? And so that's something you have to figure out. So for instance, if you're looking only women who are at risk for becoming pregnant, but looking at that, if you're just looking at women, not every woman can become pregnant, right? There's a lot of factors that go into that. So definitions are extremely important here. So if you're looking at, you could say, well, how about we only use women 15 to 44 who are likely to become pregnant? Like, well, there are people older than 44 that become pregnant. There are people younger than 15 that become pregnant. My dad, who was a CRNA, he, before he retired, practiced in L&D, labor and delivery, for decades. And I think the youngest patient, I remember he always would come home and be like, this is why I got to be careful with the ladies, because, he delivered a baby for like a 10-year-old, right? There are extreme examples of this where your denominator can be a little bit in flux. And so that's why your definitions are really important here. And when they look at a definition, like how you can apply that back to your patient, does that actually apply or not? A proportion of those women, even if you looked at just 15 to 44, maybe they've had a hysterectomy, or maybe they have other reasons that they are sterile and cannot be at risk for pregnancy, right? So those are things you have to consider. And again, defining who is at risk is one of the most important things to see. Does that apply back to your patient? If I have a 46-year-old patient who is now pregnant, this information does not apply to me anymore, right? So when you're looking at risk of death from an infectious disease too, it gets really complex as well. And so this is kind of very topical for what we're kind of going through now. But you can see that there's a whole numerous bunch of subsets of the population to consider, right? And so we'll look at this in just a picture in just a moment here. We can see each of these are a subset of the one above or below it, I should say there. And each of this is going to be a subset of the total population. So imagine you have the total population here of the US. Let's just focus on the US because that's where we're at. You can see here who are the number of people who happen to be susceptible to a disease state, right? Or a particular infectious disease, for instance. Well, are some people vaccinated and all of a sudden they're taken out of the number of susceptible? Perhaps, maybe not. Then you look at the number of people who actually get exposed. Notice it's a subset of the number of people who are susceptible, which is a subset of the total. And then you drill down deeper and deeper. So now you have the number of people who actually get infected. Well, not everyone who's infected actually goes on to become symptomatic, right? But some subset will, and they become ill. But just because you become symptomatic from an infectious disease doesn't mean you're going to die from it. Some people do. So you keep noticing it's smaller and smaller portions of the pie that we have to be able to define to say what a patient's risk is. That way your risk of catching something like COVID is a very different number than your risk of dying from COVID, right? So those are things we have to look at. And again, defining our populations is a portion of that. So again, when we look at this, the proportion of people who actually are ill, who actually become symptomatic from the disease in question, that die, that's called the case fatality ratio, okay? These are good definitions to know. But basically, the higher the case fatality ratio, the more virulent the infection is, meaning the more likely it is to cause death in people who become symptomatic. So that way you see a lot of things like, well, how virulent is COVID-19 versus something like influenza? They want to compare that because we know about flu. We know roughly what the death rates are like with flu. We want to compare the unknown with what we do know to see if they are comparable there, right? Let me hear comparisons like that. The proportion of people who are infected who become clinically ill is called the pathogenicity of the organism, right? So if you have a disease state where a lot of people catch it but do not become symptomatic, it's not very pathogenic, right? It didn't really cause any symptoms or signs in those patients there, okay? And then the number of people who are exposed who become infected is called the infectiousness of the organism. So something that's very infectious means that a lot of the people that are exposed tend to become infected, right? Unless they're doing certain protective measures and things like that, which may be part of the epidemiology sort of impact of like things like social distancing and mask wearing and all that sort of thing, right? So when we're looking at risk, we're going to see there's going to be some limitations to this. There are some downsides. So this is actually a big topic. I'm wondering if I should even get into it now. I'm going to say no, because we're actually going to be transitioning from something from risk to something called rate here. We're going to look at the force of mortality, but I want to save this because it's a bit of a basically it's like the rest of this lecture here, and I think I probably fried your brains enough. But we're just going to remember that we ended on slide 34 here, which is about halfway through, which seems appropriate. Kind of lecture and a half done. So let's go back and see if there's any questions here on this sticky board. So when we said period prevalence versus point prevalence, what is the difference? Very good question. I think I have it on a later slide, but if you were to look back at the PowerPoint here, if we go back to this slide here, period prevalence, instead of just looking at like point prevalence, which is a single point in time, period prevalence looks at that over a period of time. So if you were to look at this from time 1 to time 2 over that year period, if you wanted to look at new incident cases, you would say, okay, well, 3, 4, and 7. There's those 3 incident cases here. Or, I'm sorry, 5. There's 4 of them. So 3, 4, 5, and 7. So there's 4 incident cases here. Point prevalence is, again, just at a single point. So if you look at T1, point prevalence is 1, 2, 3, and 4. Period prevalence would be looking at the number of prevalent cases at the start of a time period in addition to any incident cases that happened throughout that time period. Okay, so period prevalence would include, if I was looking at this 1 year, period prevalence would include 1, 2, 3, and 4 people who are at the start. So that was the prevalence at the very beginning. And then include everyone who is a new incident case. So 1, 2, 3, and 4. So the period prevalence over this year would be 8. Okay. Again, starting off with the prevalence at the very start, and then you look for new incident cases. So it's kind of 4 plus 4. In the cases there, it would be 8, or 100% of people here are considered to be part of that period prevalence. Period prevalence is not used as commonly. Point prevalence is fairly common. You're going to see that used a lot. Again, people want to know, like, right now, what's the prevalence of, COVID in the state, right? Or what's the prevalence of influenza and, peak of February or something like that. So those are things like that. Someone said, would you mind re-explaining why the sum of the clear areas represents the prevalent cases of AIDS as of that date? Does this mean for the entire study time period or for that particular date time? So going back to that slide. So this is looking at a time period from 1981 up through 1992. And this is basically saying if you're in the dark portion of the bar here, this means that by the end of 92, you were dead. If you are part of the white portion of the bar, this means you were alive at the end of 92. So these few people here in 1984, they were alive at 92. These few people in 85, they were also alive at the end of 92. So if I add up all of these white bars together, I can get an idea for the total prevalent number of cases of AIDS are at the end of 92, along with the individual incidents of new cases in 92. Okay? Hopefully that makes a sense. There's only 2 I see. Do you guys have any other questions before I let you go? Hopefully this is, some people find this section to be a little more interesting than others. So hopefully you find it somewhat interesting. Hopefully we can keep it relevant. I think, it's funny, every year it seems to be like a new disease state tends to be the thing I get to talk about. A couple of years ago it was like Zika. Now it's COVID. Obviously it'll probably be COVID for the next decade. I'll have to talk about it at this rate. Molly is saying, so if the patient dies during the study, does that not go towards the prevalence? That depends on how you're looking at it. So for instance here, let's go back to that slide where we are looking at this graph here, or this chart here. It depends on where you're setting your prevalence, right? So if I were to look at T2, if I was to look at the prevalence of disease in this at this time point, I would say it's 1, 2, and 3. So 3 out of 8 would be the prevalence here. Even though like number 4 got the disease and then died by the end of it, they are no longer included in the prevalence at time 2. Okay, they are included if you did the point prevalence the period prevalence for T1 to T2, but not part of the point prevalence at T2 specifically. Okay. What other questions can I answer for you? Oh, but for the AIDS cases, let's see here. So you said, so if a patient dies during the study, does that not go towards the prevalence? Right. So if you are dead, you cannot be counted in the number of active cases currently. So because of that, if you die, even if you died in 92, even though you got diagnosed that year, if you died by the end of the period, you are not considered to be a prevalent case because you no longer have the disease because you're dead, basically. Not you personally, but the person is dead. Yep. All right. Any other questions? Otherwise, you guys are free to leave. Thank you for joining me. I appreciate all 27 of you for being here. Again, it's way more interesting to do it with you guys present because you can ask questions. We can converse back and forth a lot better than me just chatting with myself for 2 hours straight. So I really appreciate you guys being here. Nothing else. I will see you all next time.